Yes.
Good evening, everyone. It's a great pleasure and welcome you all for today's webinar, Oncology Cancer Treatment Updates 2023. I would like to invite Dr. Sunil Gupta, sir. Sir is a Director and HOD, Department of Hemato-Medical Oncology, Bone Marrow Transplant, Venkateshwar Hospital, New Delhi, for giving the welcome note. So please start.
Thank you. Very good evening, dear friends. At the outset, I really thanks the sponsor of the scientific program on oncology cancer treatment update. December 2023, I personally feel this is the last meeting for cancer point of view. Today we have a update on a lung cancer. And everybody knows about that. There is a revolution in the treatment of lung cancer, especially the adenocarcinoma. We have so many subtype, we have so many targets. So today we will refresh our mind and fresh knowledge by the randomized trial. What are the real world trials? So we have three deliberations today. One is on the safety of EGFR TKI. Which one to choose is a really a question. First generation, second generation, third generation. Which one is better? Why? What are the randomized trial shows? What are the efficacy, side effect, tolerance, and what is the real world picture for safety point of view of EGFR TKI? And everybody knows that once there is adenocarcinoma, we are going for a molecular diagnostic biomarker test to see which target we can hit, what is the importance of biomarkers, what are the different biomarkers. One of the speaker will talk about this. And third talk is basically a real world picture of third generation TKI osimertinib. What is the randomized trial shows? What is the real world picture? And why this is better as compared to first generation TKI, followed by a case discussion on management of early lung cancer. We need that every expert will share their experience. I personally feel this is not the lecture, this is the experience sharing meeting to all of us. And every speaker share their experience, what are the evidence, and what we can do in a present era if subtype of lung cancer is diagnosed as per the biomarker report. So for first deliberation, I would like to call Dr. Sumit Goyal. Dr. Sumit Goyal is a associate director of medical oncology at Rajiv Gandhi Cancer Institute, Delhi, and he will basically give opinion regarding safety of EGFR TKI, which one to choose and why. Dr. Sumit Goyal, please.
Good evening, sir. Thank
Good
you very much
evening.
for your kind introduction, sir. And thanks for giving us this opportunity today to interact and have a wonderful meeting. As you rightly said, probably this is going to be the last meeting of the year, sir. So not taking much time. So I'm sharing my screen, sir.
Yes.
So I hope my screen is visible and I'm
Yes, Sumit. Very
so
clear.
again, so, sir, my topic that has been assigned to me is safety of EGFR TKIs, which one to choose. So we know in today's era, we have so many drugs are there which we can choose from. There are choices, but again, we need to be wiser. It is not that one TKI will work for all, but still we need to choose the best for our patients. Again, we look at the safety profile. So the slides have been provided by Astra, and so just 1 minute, sir. So stage 4 non-small cell lung cancer. We know what is metastatic stage 4 lung cancer. So anything which is outside the lung or onto the contralateral side, or there is a effusion which is positive for malignant cells, whether it is the same pleural fluid or it's the pericardial fluid or it's the extrahepatic, extrathoracic disease. So we consider it as metastatic disease. So the common sites of mets we all know is either brain, bones, liver, adrenals, or kidney. So So the diagnostic workup, again, we know the biopsy is the standard. We need to have the tissue diagnosis. We cannot only rely on molecular markers alone at the time of presentation. We need to know the histology, and the molecular testing is important. So for that, we know the adequate tissue for histology subtyping biopsy is very important and is must. Again, once we get the report of adenocarcinoma, somehow we get excited because the possibility of finding a oncogenic driver is higher in adenocarcinoma, that we all know. But again, we know it is worth waiting for oncogenic drivers, but it may take time up to a week or so. So again, the NGS we need to know, but that can be used to know the broader aspect of array, or the broader aspect of gene arrangements and the mutations that might be present in the tumor. So again, at this point of time also, we all know we are doing rebiopsy at time of progression. We all know the reasons, what are the patterns of resistance, and whether something can be done about that. In this scenario, liquid biopsy is important, and that can be done if tissue diagnosis is not possible. So if we look at the current paradigm of treatment, so our current metastatic non-small cell lung cancer management, it is driven by the molecular testing, which is important. Again, based on earlier, we have either chemotherapy. Chemotherapy, it was based on histological subtype to a certain extent. But in today's precision medicine era, we have targeted therapy, which is genomics driven. So we need to know what we are dealing with. If the oncogenic driver is there, whether it is the EGFR, whether it is the ELK, ROS, or something else. So definitely it has changed our treatment paradigm and aspects, and it has become the mainstay of the treatment. So again, why so? Because there is a clear-cut difference in the survival. With chemotherapy, we had the overall survival of 8 to 12 months at the most. But as shown by Flora alone, with EGFR mutated patients, it can reach up to 4 years also, which is considerable jump. So if we look at the targeted therapy for adenocarcinoma with driver mutations, we know there are multiple driver mutations are there in the lung cancer. And we have so many EGFR sensitizing mutations, which constitute about 17%. If we look at all the driver mutations are there, which is there in 2/3 of the patients in the one aspect or the other. So coming to the EGFR sensitizing mutation, we know osimertinib, it is the standard of care. Then we have first generation and second generation medicines also, like gefitinib, erlotinib, and afatinib, dacomatinib. So EGFR mutation, which result in sensitivity and resistance to EGFR TKIs, they tend to cluster at exon 18 to 21 in non-small cell lung cancer. So if we look at this bottom chart on the right side, so it is the frequency of mutation type which is there. So exon 19 and exon 21 are the most common mutations which are there, which are close to about 80% of the patients, they have these mutations. The other rare mutation, exon 18, is there. And we know the exon 20 insertions are there, which to certain extent are resistant. And fortunately, they are present in less number of patients. So if we look at the EGFR positivity rates across the globe, so it is present in approximately 50% of the patients, Asian patients, and 10 to 20% of the Caucasian patients with non-small cell lung cancer patients. For India, our country, we have EGFR positivity rate of about 25 to 30%. And the most common mutations which are present, they are either exon 19 deletion, which was shown in the data, about 42 to 50%, and L858R in exon 21, which is there in 1/3 of the patients. So TKI is the standard first-line option. So there are other mutations in the EGFR domain, which are uncommon also and sometimes resistant to first-line therapy. So if we look at the history of EGFR TKIs, so the 1993, the EGFR target therapy started to develop. And again, it was started in 2004 when it was found. Earlier than that, we were in initial days giving the EGFR TKIs empirically, adenocarcinoma, females, Asian, non-smokers. So that's how it started. But later on with different studies, starting with IPAS, INTRUST, Lux Lung, other studies, Aura and Flora, we know that TKIs work in this thing. Whenever we talk about the opportunity to treat we look at two factors. One is effectiveness. At the same time, we look at the safety of the patients. So if we look at the efficacy, so these are three different trials comparing first, second, and third gen of medicines. So Lux Lung 7, the patients with brain mets were included in the study, and apatinib versus gefitinib, they were similar, and not a much difference, but they were like showed apatinib showed little superiority over the first generation, and but the benefit was visible only after a year or so. Then coming to second generation versus the first generation, the other drug was dacometinib, which was compared with gefitinib in Archer 1050. Again, it took about 6 months for curves to separate to show the benefit. But once we talk about third generation Flora study, osimertinib, the results were visible quite early, and these patients also had patients who had brain mets. Again, we need to have this with a word of caution, because we cannot do cross trial comparison is not easy, and we should not be doing it. But just for the sake of clarity, just to show, yes, the osimertinib is effective and uh, effective drug, and it shows results quite early in the treatment paradigm. So if head-to-head studies in second and third generation EGFR TKIs, they provide that significantly longer PFS was there as compared to first generation TKIs. So whether it was gefitinib and erlotinib, apatinib versus gefitinib, or dacometinib versus gefitinib, so there was benefit in PFS in all the subgroup of the patients. So basically, we know PFS is a direct measure of the drug benefit. Immediate separation of PFS Kaplan-Meier curves in Flora study shows, yes, it is effective study. And the osimertinib in Flora first time provided unprecedented improvement in PFS. So if we talk about safety after the effectiveness, safety is the prime concern in this talk today. So the first generation and the second generation drugs, they are designed to selectively target EGFR sensitizing drug the mutations. But osimertinib again is a difficult T790M mutation is a difficult mutation to target, and first, second, and third generation, they usually do not target T790M, whereas third generation, it does target in the first line itself. And if you look at this chart, so last line bioavailability, it is there, and apatinib we do not know, and the doses and all we know. So the differences between the structural differences are there, but the crux of the story here is ability to cross the blood-brain barrier by their structural nitty-gritties. So the osimertinib, it has a significant penetration in the brain. So blood-brain barrier, it penetrates. So patients with brain mets there is an advantage. So this is another important chart showing the relative sensitivity of T790M to the relative concentration of the drug in the drug. Gefitinib, to target T790M, we need doses which are much beyond the tolerable doses. So cannot be targeted in a way, we can say. Apatinib, the second generation, again, the doses are more than 10 times. That is, we can tolerate. But with the selectivity of osimertinib to T790M, we can see even the doses less than the recommended doses, T790M mutations, they are sensitive for osimertinib. So if we look at the side effects, again, this is a complex chart giving all the frequency of severity. So again, to cut short, if we look, the second generations, they are pan-ERB inhibitors. So there is a lot of toxicity which happens because of pan inhibition of ERB receptor. So one of this is rash and diarrhea. So the other thing which is there, liver dysfunction, raised ALT, AST, it is more frequent among patients treated with gefitinib. The reason we don't know. So if we look at the safety data, again, cross-trial comparison, which we should not be doing. So in a nutshell, this was the crux of the story. AEs of any grade were much higher with dacometinib in Archer 1050 as compared to osimertinib in Flora. We can see in this chart. In dacometinib, the important being the diarrhea, which was there in 87% of the patient, as compared to 58% in the osimertinib group. Same way, all the side effects are much more in the Archer study with dacometinib as compared to osimertinib in FLORA. So if we talk about the tolerability profile of EGFR TKIs, we know if we look at the second line, last line, which is highlighted, adverse events more than grade 3. So 49% of the patient, they had treatment-related side effects in the Lux Lung 3 study. Again, dacometinib in Archer 1050, about 63% of the patients, they had some amount grade 3 side effects, which were comparatively much less with osimertinib and FLORA. It was only 18% treatment-related side effects were there. And leading to dose modification reduction, it was much less in FLORA study with osimertinib, just 4% as compared to 52 and 66% in apatinib and dacometinib studies respectively. So second generation TKIs have unfavorable tolerability as compared to third generation of TKIs. So again, safety data. So again, grade 3, 4 A's with dacometinib were reported in 63% of the study in Archer 1050, which were much less in the osimertinib in FLORA study. So if we look at the safety data, the key safety data summary. So dose reduction, it was 66% of patients in Archer study, whereas it was just in 3% in the FLORA study. Serious adverse events, it was 27% in the Archer study, just 4% in the FLORA study. AE leading to death, it was 10% in the Archer, it was just 2% in the FLORA study. So the side effects were much less, efficacy much more higher as compared to second versus third generation drugs. So if we talk about safety of EGFR TKIs, what are the similarities and differences? So as first-line treatment, second-gen EGFR TKIs lead to higher frequency of AEs that are associated with pan inhibition of ERB, such as rash and diarrhea, as compared to first or third generation of drugs. So if severity does not happen or does not lessen or cannot be managed, the EGFR TKI dose we need to reduce, and it has to be reduced. The dose adjustments were much more frequent with second generation TKIs. Osimertinib, with our practical experience, we see the dose reductions are much lesser as compared to the other two. So again, if we look at the dose modification, this is the same thing. Lux Lung, 52% versus 19% required dose reduction in second versus first gen. In Archer, 66% versus 8%. In FLORA, it was almost similar in both the groups, 4% versus 5% respectively. So the data which is available to us at this point of time, looking at the studies and cross-trial comparison, these data suggest that dacometinib is often intolerable at starting dose of 45 milligram per day. So dose reduction resulted in lower incidences of severity of grade 3 AEs. But if the dose reductions were done, so the next question which comes to our mind automatically is whether it will impact our outcomes or not. So which was like an important question to answer. So even after dose reduction, the incidence was much higher compared to osimertinib in FLORA. That is another thing. Third generation, even after it was still better in the standard doses as compared to the other arm with dose reduction. So also the important point with dose reduction is the efficacy. The post hoc data analysis are an issue, but they confirm to neither the population nor the randomization model of statistical interference. So the difference, even if it was there, that the data, if we go back, it shows the probably the median PFS, it was the similar or benefit even after dose reduction, but it does not hold true with the statistical calculations. So coming to the quality of life, so the Lux Lung 7 compared apatinib to gefitinib, it showed it was similar improvements in quality of life in both the treatment arm. Whereas in Archer 105, so it studied the overall quality of life improved significantly from baseline in patients treated with gefitinib rather than the dacometinib. So it was the other way around. But in flora, osimertinib showed there was a consistent trend towards better improvement across scores compared with gefitinib. So, however, it does not reach the clinical significance. So, looking at the charts, so the global quality of life, it significantly worsened in the dacometinib group as compared to the gefitinib group in the Archer study, which is clearly evident here. So again, we know one of our goals in stage 4 disease to improve quality of life, which we need to remember. And sometimes it is not acceptable to the patients that their quality of life gets compromised. So again, these are the studies, the different questionnaires, FACTL, TOI, LCS in different studies across. So I'll skip this. So basically, the quality of life index was measured and it was improved in third generation also as compared to first and second generation. So talking about the management of adverse events, acneiform rash and diarrhea, just quickly what we do, how to do it. So if we look at the percentage of patients who get the diarrhea, osimertinib arm, it was very less patients who had the diarrhea and the stomatitis. And if we look at the rash, we know the grade 1 rash is less than 10% of the body surface area if it is involved. Grade 2 is 10 to 30%. And if it is more than 30% erosion, vesicles, desquamation, then it is grade 3. In grade 4, we get the area is more than 30%, but there are erosions, ulcerations, peeling of the skin, and patient requires admission. So management, we all know the skin rash, grade 1, just topical anti-inflammatory or antibiotics are sufficient. And in grade 2, we need to give oral anti-inflammatory antibiotics, doxycycline 100 milligram BD for 4-5 days or 7 days. Steroids, we need to decide whether to enter. Grade 3, definitely we interrupt the doses and we need to give prophylaxis for secondary infections and continue with the grade 2 management. And grade 4, definitely we need to admit and we need to have seriously monitor the patients. So again, coming to the osimertinib and acneiform rash, same thing, we need to reduce the dose. We can either start at the same dose or we can reduce to 40 milligram daily also. So diarrhea, again, grade 1, 2, 3, 4. So we know less than 4, 4 to 6 or more than 7 loose motion per day classify as grade 1, 2, 3. 4 is whenever we need to admit the patient or life-threatening. It is suspected to level, it is labeled as grade 4. So grade 3 and 4, it is medically complicated. We need to aggressively manage. We need to interrupt our treatment and monitor the patients and reintroduce at a reduced dose. So again, we need to start the antidiarrheals at the earliest and dose interruptions we need to do. So this is the standard we all know. We start with loperamide as soon as the diarrhea starts, if it is grade 2 or 3, and we continue till the time it stops. And grade 3 and 4, definitely we need to admit. So for osimertinib, any adverse reaction more than grade 3, we need to withhold our treatment for 3 weeks. It may be up to 3 weeks. If the reaction improves, then we need to resume at lower doses. Does not improve, we need to discontinue our treatment. So in summary, second generation TKIs are burdened by toxic profile, though they have shown PFS benefit as compared to first generation. But so the benefit has also shown by third generation TKI osimertinib, but it is a side effect profile which is not favoring it. So as compared to dose reductions and AE leading to dose discontinuation, it was much, much higher as seen here. Archer versus Flora, 66.1% versus 2.9%, and grade 3 or above adverse events were reported in more than 60% of the patients. Again, the quality of life was again not very good in this subset of patients. So we have, on the other hand, third generation osimertinib with far superior clinical profile, be it efficacy, tolerability, CNS activity, and quality of life. So again, our guidelines incorporate the same thing. It is a category 1 recommendation, though there are other drugs in category 1 recommendation, but it's a quality of life, efficacy, tolerability, which make it a favorable drug. So the takeaway drugs, the points were the same. It is a better drug, good tolerability, and good efficacy. On the other hand, second generation TKIs, we can choose and use them, but they are burdened by toxic profile and poor quality of life. So with this, I'll stop here and I'll hand over back to Sir.
Thank you, Dr. Sumit, for such an excellent talk. In brief, you have explained everything regarding the safety, efficacy, and quality of life. I would like to call for a second scientific deliberation by Dr. Chitresh Agarwal on molecular biomarker testing in lung cancer. Dr. Chitresh Agarwal is a senior consultant medical oncologist from Punjab. Chitresh, I don't know about your place where you are working. Please introduce yourself.
So, good evening, sir. Thank you. I work at Paras Hospital, Panchkula.
Okay, you have
And
shifted because I want that I should say something, but I know that you have changed. That's why I didn't
yeah,
mention about the hospital.
yeah. So, the topic assigned is molecular biomarker testing in lung cancer. So,
Yes, Chitresh.
yeah. So, the overview of the talk would be the incidence of lung cancer in India, biomarker testing, evolution of biomarker testing, and some key takeaways. So, we all are aware of the burden of the lung cancer in our country. So, in 2020, if we see the incidence, it is the second most common cancer which is occurring in the males, just after lip and oral cavity cancers, and it constitutes a significant health burden in cancer patients. So it is not only the incidence but the mortality also, which is very serious for lung cancer, and significant number of patients lose their lives every year due to this disease. Now, 50% of the patients with adenocarcinoma who are diagnosed with lung cancer, they have driver mutations targetable with an FDA-approved agent or on a clinical trial. We all are aware of the incidence of these mutations and the drugs available, but just for the mentioning sake, we know the general incidence of EGFR mutations range from 17 to 30%, KRAS mutations around 25 to 30%, ALK around 3 to 7%, and then all other uncommon mutations like MET, HER2, ROS1, BRAF, RET, PIK3CA, NTRK, anywhere between the range of 1 to 3%. And we also are aware of the TKIs that are available against these mutations. We know EGFR sensitizing mutations like the drugs available like osimertinib, geftinib, erlotinib, afatinib, dacomatinib. Against ALK, we have alectinib, crizotinib, ceritinib, lorlatinib, and brigatinib. KRAS, though it is not available to us, but still in clinical pipeline, it is sotorasib and adagrasib. And EGFR20, there is a drug available, amivantamab and mobocertinib. And then for HER2, we have trastuzumab deruxtecan. For ROS1, we have crizotinib. For BRAF, dabrafenib. For NTRK, fusions entrectinib and larotrectinib. And for MET exon 14, we have capmatinib and tepotinib. So these are the common drugs that we use in our day-to-day practice for patients who are diagnosed with sensitizing driver mutations, who are adenocarcinoma lung stage 4 patients. Now, why it is important? It is important because patients who receive the targeted therapies during their treatments, they do well in comparison to patients who do not receive targeted therapies. And this is the overall survival shown here, where the patients who receive targeted therapies, they have a median OS of around 18.6 months versus 11.4 months, where no targeted therapy was used. Now, the guidelines, whether they are ASCO guidelines, the NCCN, ESMO, or the CAP IASCLC category guidelines, they all recommend the testing of all the mutations that I had previously mentioned. The NCCN and the IASLC guidelines also suggest testing for KRAS mutations because KRAS mutation indicates poor prognosis, and patients with KRAS mutations are unlikely to benefit from other molecular testing. So KRAS testing is not only predictive, but it is prognostic. And as I previously mentioned, we will have shortly a drug against this mutation also. Now, what are the methods of tissue testing in non-small cell lung cancer? We have the basic conventional tests like IHC and FISH. IHC will detect the ALK ROS1, and the FISH detects the ALK ROS1 highly specialized. It can be faster. Then we have the sequencing panels in DNA and RNA. So RNA sequencing panels, it will detect the fusion abnormalities. And the DNA sequencing includes NGS and PCR techniques. They detect the insertions, point mutations, and deletions. And they also detect the aberrations in EGFR, KRAS, BRAF, HER2, MET. And then nowadays in our practice, we are all ending up using a single gene or a full NGS panel where all these mutations, in a bucket are handed over to us after testing. So how did the evolution of biomarker testing in NLCLC happen? So we all started with the tissue diagnosis where you used to take a biopsy, a small tissue biopsy or a resection or excision, make a block, send for histopathology and cytology, and then further investigate depending on the techniques available. Also, in addition, where sometimes tissue is not possible to take a proper biopsy or a resection specimen was not possible, we are using cytology in the help of FNACs or exfoliative cytologies, and then making cell blocks out of those, and then sending for further testings. And nowadays, the latest thing is liquid biopsy, where for patients where biopsy is not possible, we check the blood or the fluids, the ascitic fluid or the pleural fluid or the pericardial fluid, and make the tissue out of that, and not the tissue exactly, but the circulating tumor DNA cells or the DNA out of that, and then ultimately test for all this information. So biopsy, histological subtyping into squamous or non-squamous. For biomarker testing, primary tumors and metastatic lesions equally suitable. Biopsy and bone biopsy can be suboptimal due to decalcification and degradation of DNA. But for such patients, liquid biopsies, cell-free DNA in plasma are another options. Now we have to always test for all these mutations like EGFR, ALK, ROS1, BRAF, NTRK, RET, MET in all non-squamous non-small cell lung cancers. As I previously mentioned, we have to use a broad NGS test to detect most mutations. And sometimes in squamous histologies also, if the patients are young, they are never or light smokers, we should, on a clinical basis, test for these mutations, because some of these patients also, those squamous, might come out to be positive. We have to test for PDL1 expression, and the general turnaround time is 10 to 14 working days in all our practice. Now coming to ctDNA testing, ctDNA testing is being used for diagnosis and treatment selection, is being used for monitoring prognosis and response to treatment, and it is also being used to overcome some major challenges which are associated with tissue testing. So as I previously mentioned, sometimes the biopsies are not possible, or sometimes the patients are not willing for repeated biopsies. ctDNA can be a very important tool. So ctDNA testing may never replace a tissue biopsy entirely, but it could have a complementary role to support treatment selection in patients who are non-small cell lung cancer. So, patients, the ctDNA testing could identify patients at risk of relapse or allow for inappropriate, for appropriate intervention, because the presence of MRD may be used to predict the disease recurrence, though currently cannot be identified, but it is a scientific, thought, and it is being evaluated further. Now, if you see the TRACER-X study, 24 early stage non-small cell lung cancer patients who were studied after resection, phylogenetic ctDNA profiling was done, and 93% of the patients with disease recurrence were MRD positive. So the ctDNA profiling was able to confirm the MRD negativity, and just like hematological malignancies, the detection of MRD could be a very important tool to detect early recurrences in solid cancers like lung cancer also. Now, what are the key differences between tumor tissue and liquid biopsy? We all are aware that for liquid biopsy, we have to simply draw blood, generally 10 ml in whole blood. It is a minimally invasive procedure. It directly correlates between the ctDNA results with histology or cell type is not possible. It is a very sensitive method because the ctDNA may comprise less than 0.1% of the cell-free DNA, and the standardization is still not very established techniques, and still we are day-to-day learning on this standardization. And the evidence of clinical utility is less, but as the science is advancing, we have more and more evidence of its clinical utility. Now, these are the multiple platforms on which we have to identify these mutations, and we work and treat our patients depending on what results we find. So what are the advantages of NGS? So NGS, as the number of clinically actionable biomarkers have increased, we have the ability to evaluate all non-molecular alterations in a single test, and that has given NGS a major advantage. Now, what are the major pros of using NGS versus a single gene test? Because it detects a broad range of molecular alterations, and it may identify new markers that could offer additional treatment options. But in the same setting, what are the cons? The cons are that high complexity of workflow that requires experienced personnel, and advancements in the NGS are revolving rapidly, and may receive sufficient time later on. So what are the techniques that are used frequently for mutation detection? We have the NGS, which is being used very commonly nowadays. We have, other allele-specific PCRs, gene panel assays, but next-generation sequencing is coming into vogue on a day-to-day basis very commonly. So this is the same thing that I showed earlier. Now coming to the EGFR mutation in lung adenocarcinoma, the FFP sections, fresh, frozen, or alcohol-fixed specimens can be used for PCR-based assays. The cytology samples are also suitable, and cell blocks are always preferred over the spheres. And the discordance between the EGFR mutations in primary tumors and the corresponding metastatic sites are always very rare. So whether do it at the primary site or the metastatic site, the concordance is very high and discordance is very low. Now, EGFR mutation test in early lung cancer, we all are aware nowadays of the data, and we should always consider additional molecular testing to EGFR mutations to be performed on diagnostic biopsy or a post-surgical resection to ensure that EGFR mutation patients are available for adjuvant treatment decisions. So we have adjuvant osimertinib nowadays for patients from 1B to 3A non-small cell lung cancer. So not only in stage 4, but for adjuvant EGFR patients also, we should be able to pick up these patients and offer oral TKIs in the adjuvant setting. So what are the advantages of NGS over PCR? One study showed that 48.6% of the EGFR exon 20 insertions mutations identified by NGS are missed by PCR. Okay. So out of 17 most common EGFR exon insertion mutation variants, only 4 could be identified by PCR. So NGS in picking up these mutations is more sensitive, and it is able to pick up more number of mutations and insertions over PCR. Now coming to the ALK arrangements in non-small cell lung cancer, the false positivity is very low. IHC is less expensive, hence it is more widely adopted. Earlier we used to do only FISH, but now IHC is also a very standardized technique to detect ALK positivity. Coming on to the ROS rearrangements in non-small cell lung cancer. So this is the algorithm where we do the EGFR, we do the ALK, and then we do the ROS by IHC and ROS by FISH. So detection of elevated ROS1 protein levels by IHC may actually be cost-effective screening prior to a confirmatory FISH testing. So coming to the RAS pathway, KRAS mutations are mutually exclusive with EGFR and ALK and accounts for nearly 30% of the lung adenocarcinomas. So the most common of these arise in the codons 12 and 13 with the G12C variant, which is predictive of a very poor prognosis in comparison to a wild-type KRAS. So what is the method of detection? Single gene KRAS 12G testing is not currently recommended and should only be performed as a part of the multi-gene NGS panel. And as I previously mentioned, we have now some targeted therapies like sotorasib, which is currently approved for patients with non-small cell lung cancer. Now coming to the BRAF mutations, again, the BRAF V6C mutation is present in more than 50% of the BRAF mutation cases, and it is thought to be more prevalent in smokers. And overall, the BRAF mutations, they constitute around 1 to 5% of the patients with non-small cell lung cancer. Again, NGS as a broad spectrum panel would be able to pick up the BRAF mutation. And we have currently approved therapy in the form of dabrafenib plus trametinib. And this is an effective therapy for patients who are BRAF positive lung cancer, though they have a very poor prognosis. Now coming to the MET genes, a normal role in embryogenesis and wound healing, we are all aware. In cancer, the MET exon 14 skipping mutation, it causes in-frame deletion of the juxtamembrane domain, which results in increased stability and the constitutive kinase activation. It can be to the tune of 3 to 4% in non-squamous non-small cell lung cancers and to the tune of 20 to 30% of sarcomatoid cancers, which go through this pathway. So the majority of MET exon 14 skipping mutations can be detected via DNA NGS, but it has increased sensitivity with RNA NGS. Now, what are the methods to pick up MET exon 14 mutation? IHC and FISH are not recommended. As I told you, RNA is more sensitive, but it has technical considerations. And NGS, DNA dependent, design dependent, potentially detects many mutations, and RNA NGS is the most sensitive method. Now coming to the RET. So RET receptor tyrosine kinase and RET fusions are also, they happen normal role in neural genitourinary development, but in cancer, RET gene rearrangements give rise to chimeric cytosolic proteins and they constitutively active the RET kinase domain. Again, the majority of the red fusions can be detected by DNA NGS, but have increased sensitivity with the RNA NGS. So what are the methods? IHC, potential local implementation. So cons, it is significant false negative. Consider using no. Fish, rare circumstances. DNA NGS, it can be used, but the most sensitive and the most dependent of all is the RNA NGS. Coming to the anti-RK fusion testing. So we have the options of...
Sir, kindly conclude your talk in 2 minutes, please.
Okay, so just moving on to the less mutations like the HER mutations we all are aware of. So 2022 treatment algorithms for biomarker positive, as this I've already told, whatever mutations we pick up, we have drugs available against all these mutations. So coming to the last slide of PDL1 overexpression, now we have various platforms dependent PDL1 testing. These are companion platforms. For pembrolizumab, we generally have 22C3 DACO. For 263, we have Ventana, SP142 for atezolizumab, and DACO again for nivolumab. And the scoring system we generally see for PDL1 positivity, and we label it as 1 to 50% or again very high, which is more than 50% alone. So this is again the same thing. So to conclude, biomarker testing in non-small cell lung cancer has evolved from a single gene to a multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirements. Sample should contain adequate tumor content, at least 10%. Ideal turnaround time is 2 weeks, and high throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated turnaround times. So these are the mutations that we have shown you, and we have the various methodologies through which we can test them. Thank you.
Thank you, Dr. Chitresh, for such a wonderful talk on a biomarkers, and this is a real world picture. Now I would like to call the third deliberation by Dr. Devinder Pal. He is a senior consultant medical oncologist. He will tell us about the real world evidence of osimertinib in the treatment of EGFR mutation non-small cell lung cancer. Dr. Devinder Pal, please. Please introduce yourself because I don't know about your place where you are working, please. Dr. Devinder.
Good evening.
Good evening, Devinder.
Hi, sir. My name is Dr. Devinder, sir. I am a senior consultant and HOD of the Fortis Ludhiana. Previously,
Okay.
I was head of the department in the Medical College Ludhiana.
Okay.
And now I'm in Fortis Ludhiana.
Okay. I know Dr. Sheko was there, my contemporary friend.
So now I'm also Dr. Seko Fortis, right?
Oh, yes. Yes, Dr.
Somebody
Devinder.
can upload the slide, please. Can somebody upload the slides for me?
Ashish.
Yes, sir. Yes, sir. Just a minute. No?
So good evening, all. I'll be discussing about the real world evidence for the osimertinib as it has been established as standard of care in the management of EGFR mutant NSCLC. Next slide. So we all know that in patients with EGFR mutation, PFS improves after treatment with EGFR TKIs compared to that of chemotherapy. Osimertinib is now the standard of care. It's an irreversible third generation TKI, and it has demonstrated a clinically meaningful improvement in the median PFS or to the tune of 18.9 months versus 10.2, and the phase 3 randomized FLORA trial. And the OS median is around 38.6 months versus 31.8 months with the HR of 0.8, and it has made the osimertinib the best treatment option available for these patients. Next slide. So I'll be discussing the real world evidence. I'll be discussing 3 trials. The first trial is the osimertinib as comparator EGFR TKI as first line treatment for these patients. A FLORA trial. I'll discuss about the final overall survival analysis. Next slide. So we all know FLORA is a double-blind study design. You can see the inclusion criteria. They also included the exon 19 deletion and the L858R also. And stable CNS mets were also allowed. Stratification was, you can see, either osimertinib or the comparator EGFR. and they were evaluated as per the RECIST criteria. And crossover was allowed for patients with in the comparator EGFR arm who received open label osimertinib upon central confirmation of progression. The OS was the key secondary endpoint, and for statistical significance, a p-value of less than 0.0495 was determined by the O'Brien approach. At get data cut of 61 patients, that 22% in the osimertinib arm and 13%, that is 5% on the comparator arm, was still on the study design. Next slide. So baseline characteristics were equally equal in same in both the arms. You can see whether it's the age, sex, race, smoking incidence, CNS mets also, and they also randomized according to the EGFR mutation, whether it's the exon 19 deletion or the L858R. Next slide. So the primary analysis progression-free survival, you can see the PFS is beautifully maintained better in the osimertinib group, and in the you can see the comparator group, everything was favoring the osimertinib, whether it's the age, sex, race, a smoking history, CNS mets at entry, WHO performance status, whether whatever type of the EGFR mutation may be there, whether it's exon 19 or the L858R, they all favored the osimertinib arm. And the median PFS, you can see 18.9 months in the osimertinib versus 10.2 months in the comparator EGFR, with an HR of 0.46 and a very, very good significant p-value of 0.001. Next slide. So in the final OS analysis, you can see the osimertinib showed a median OS of 38.6 months compared to 31.8 months with an HR of 0.799. And you can see even at 36 months, there were 54% in the osimertinib arm, which was still alive, and as compared to 44% in the comparator arm. Next slide. So in conclusion, this study showed a statistically significant and a clinically meaningful improvement in the OS, and the median OS, as I told you, was extended by 6.8 months, and it's the first TKI OS benefit was the EGF TKI. And after 3 years, 28% patient in the osimertinib arm and 9% of the patient in the comparator arm, they were still on the first-line study, and it presented a favorable and consistent toxicity profile despite a prolonged exposure. So the final OS analysis of the study reinforced the osimertinib to be the standard of care for the first-line patients of EGFR mutant advanced NSCLC. Next slide. So in the 2021 NCCN guidelines, you can see if the patient is discovered EGFR mutation discovered prior to first-line therapy, the preferred treatment is the osimertinib. Other TKI are also category 1, but the preferred is still the osimertinib. And if the patient is already on the first-line treatment, the guidelines recommended that either you complete the planned chemotherapy and followed by osimertinib, or you can interrupt the chemotherapy and start directly on the osimertinib. Next slide. Yeah, next. Yeah, next. So real world evidence, there are 3 studies: FLOWER study, the OSIFAC study, and the MYCONO studies. Next slide. So the FLOWER study, which came in 2021, is the first time osimertinib in patient with EGFR mutant advanced NSCLC. Next slide. So this is all the same thing. The osimertinib is a third generation EGFR TKI with a very good PFS and OS benefit. The OS is 38.6 months versus 31.8 months. And it has been estimated that only 2 to 4% of patients with cancer receive treatment with these drugs, thus raising the issue of representativeness. So the real world data have become a useful tool to assess the unique insights in routine oncology practice in the post-marketing setting. Next slide. So the key feature of this study was, you can see the median age was 68, brain mets were allowed, and they were seen in almost, you can see 30% in the 30% patients. And primarily patient was a stage 4, few patients of 3B and 3C were also taken into consideration. Next slide. Inclusion and exclusion criteria: age more than 18, histological confirmed disease, presence of more than one EGFR mutation in the exon 18 to 21, locally advanced recurrent or metastatic disease, and patient should be eligible to receive these drugs. And exclusion was the patient who had received the study design in the clinical trials. Next slide. So the primary endpoint was median time to treatment discontinuation, which was measured for the osimertinib from start to discontinuation for any cause, and rate of adverse events, rate of dose reduction, or temporary or definitive treatment interruption due to AEs. Secondary endpoints were the median overall survival, median progression-free survival, overall response rate, and disease control rate. And progression pattern to osimertinib was also assessed, whether the type of progression, the number of lesions at the metastatic site, new lesions, and progression-related symptoms. And few diagnostic therapeutic pathways were also taken into consideration, like the time frame between diagnostic biopsy and histological report, the proportion of patients who are undergoing a local regional treatment, and the type and frequency of re-biopsy performed at the progression. but the main thing was treatment time to treatment discontinuation. Next. So in the effectiveness, primary assessment effectiveness, patients with poor performance status, comorbidities, and rare EGFR mutation and active brain mets were also included, which was excluded in the FLORA trial. Outcome was similar to the published data, thus adding a consistency to the osimertinib efficacy. And there was no difference in the PFS, time to treatment discontinuation, and OS were observed in the elderly patients with comorbidity, and less common EGFR mutations. Next. So if this effectiveness was assessed in 3 ways, whether the median time to treatment discontinuation was around 25.3 months. And in the second graph, you can see they were randomized whether the patient had a baseline symptoms or not, had no baseline symptoms. The time to discontinue was far better in the patient who doesn't have symptoms. You can see it was median was not reached, and the patient in whom they had the symptoms at baseline, the median was 18.8 months. Similarly, the patient was seen according to whether the number of mets were less than 3 or more than 3. In the patient whom it was less than 3 sites of met, which was a low burden disease, the median was not reached. And whereas in the patient who had more than 3 sites of mets, the median was 21.4 months. Next slide. So these studies showed that the patients with poor PFS comorbidities and rare EGFR mutation and active brain mets were included. Outcome was similar, and there was no difference in the PFS, TTD, or OS were noted in the elderly patients with comorbidity and less common EGFR mutations. Next. And the TTD appears to be more suitable endpoint to evaluate treatment outcomes in pragmatic real-world trials. And TTD was longer, that is 25.3 months, than the post-progression outcome analysis of the FLORA trial. And probably due to the study population were unfit for the further therapy. And better TTD was associated with fewer than 3 progressing sites and isolated progression compared to oligo or systemic progression. Next slide. So similarly, you can see this was the treatment outcomes. You can see if the patient had a symptom at the baseline, whether it was present or absent, the PFS by the univariate, the p-value by the univariate analysis was 0.31, and the treatment time to treatment discontinuation, even by the multivariate analysis, showed that the p-value was of 0.028. Next. Yes, next. Similarly, the patient had a less than 3 site of metastasis. You can see the PFS by univariate analysis p-value was 0.151%, and the TTD by multivariate analysis, the p-value was 0.85%, and the patient who had brain mets were present at the baseline, the PFS by p-value by PFS univariate analysis was 0.019, and the TTD by multivariate analysis showed a p-value of 0.284. Next slide. Yeah, next. So after median follow-up of 12.3 months, the median PFS was 18.9 months, and the median OS was not reached at the time of data cutoff. Most of the patient had a partial response, that is around 73%, 23% had stable disease, and only 4% patient had a progressive disease on osimertinib. Next slide. So again, you can see as median follow-up 12.3 months, the median PFS was 18.9 months, and the median OS was not reached. And as I told you, the partial response was 73 and stable disease was 23%. Next slide. So longer PFS was noticed in all the arms, and real-world diagnostic therapeutic pathway essential element of evidence-based medicine and could help clinician in deciding treatment outcome. Among patients experiencing progressive disease, 47.7% underwent the re-biopsy at progression, and tissue re-biopsy was 66.7%. Liquid biopsy was around 28.6%. And molecular analysis was performed in around 62% patients. And druggable resistant mechanisms, including the following, like the MET amplification or the MET amplification of leak EGFR, they were also seen in few of the patients. Next slide. Safety data inclusion, you can see primarily side effects with the osimertinib. We all know whether it's a mild GI toxicity, some patients have a vascular thromboembolism, but predominantly the side effect profile is very easy, and the grade 3, grade 4 toxicity was observed, were not observed in that amount of patients which was seen in the trial setting. Next slide. So as I told you, the only 3 main side effects were the skin and the GI toxicity, and 87% patient experienced adverse events of, and out of these, 33% had a grade 3, grade 4. Venous thromboembolism was the most common. It was seen as 7.9% in the real world study, Grade 3 pulmonary embolism was accounted for just 2% of the treated patient receiving osimertinib, and there was no difference in the rates of venous thromboembolism were reported according to the age, PS, comorbidity, or the tumor load. Next slide. Yes, next slide. So the other study is the OC effect study. Osimertinib is the first treatment for these patients. Next slide. So this is the same thing. Next slide. So this study, including criteria was the advanced EGFR positive NSCLC, exclusion were patients concurrently receiving other anti-cancer therapy, undergoing pre or post-operative adjuvant therapy, or who had received osimertinib as a second-line treatment. Next slide. Baseline characteristics were equal in both the arms. Next slide. They also included the PD-L1 status, which also equally randomized. And the study endpoints were the primary was the PFS, secondary was the OS, time to treatment failure, response rate, and objective response rate, and then disease control rates. Next slide. So the PFS occurred in around 182 of the 538 patients. The median PFS was 20.5 months. And the other parameters which were significantly associated with PFS were male gender, presence of malignant diffusions, liver metastasis, and advanced unresectable cases. Next slide. And with respect to PD-L1 expression, the median PFS was not reached in patients with the TPS of less than 1, and it was 14.7 months with the TPS of less than 49, 11.1 months with the TPS of 50, and it was not reached in patients with TPS which was unknown, which is all we know. As the patient has more PD-L1 expression, the chances of osimertinib or other TKI working are less. So the efficacy analysis primary endpoint, you can see they were seeing that the PFS was assessed as per the presence of smoking history, cog performance status, malignant liver mets, brain mets, mutation type, and the presence of PD-L1. Next slide. And you can see in all these arms, the PFS was better in the osimertinib arm. Regarding the treatment discontinuation profile, reason for treatment discontinuation primarily 44.3% patient had the cause were because of the disease progression, and other few causes were the presence of pneumonitis, progression of other diseases, and few patients had a loss to follow-up. Next slide. Safety profile, you can see pneumonitis, grade 4 was just seen in 0.7%. Grade less than 3 hematotoxicity was seen in 4.3%. And all A's leading to treatment discontinuation were to the tune of 16.9 months, 16.9%. Next. So the overall response rate was 76.2%, and the disease control rate was 94.1%. PFS was better with the osimertinib than with the conventional EGFR TKI, irrespective of PD-L1 expression. Median time to treatment failure was 19.1 months. Median time from start of treatment to the onset of AE was 56 days. And pneumonitis all grade occurred in 12.8%, but grade 3 or higher was seen in 4.5%, and a fatal pneumonitis was seen in 0.7%, that is 4 patients. So in conclusion, PFS after first and osimertinib treatment in real-world practice was favorable, and the discontinuation rate due to AE was 18.8%, especially in pneumonitis, which required further investigation. Next slide. Other study, the real-world study of patient with EGFR admitted to locally advanced osimertinib NSCLC treatment first and osimertinib. And background, this is the same. We all know the FLORA data, but there remains a need to value the real-world disease characteristic and clinical outcomes of these patients. And this study reported the demographic and clinical characteristics of real-world time to next treatment and real-world time to treatment discontinuation of the patients who received first-line osimertinib in the United States. Next slide. So it was a global observational prospective cohort study, which is still ongoing in the US, Europe, and Asia. And the US sub-analysis included the data from the nationwide federal health electronic record system. And during this study period, the de-identified data was originated from approximately 280 US centers. And for the entire subgroup analysis, data was collected through June 30, 2020. And the study is ongoing, and the median follow-up period is planned until June 2023. And including criteria was similar: more than 18 age, advanced disease, EGFR mutation, and initiated on first-line osimertinib. So this is the study design. First, the advanced NSC diagnosis was made. The patient identification was done by April 2018, and by March 31st, 2020, patient identification and date was there. And at the interim analysis was cutoff date was June 30, 2020. Next slide. So the baseline clinical and demographic characteristic and treatment pattern was summarized using the descriptive analysis. All the statistical analysis was done, and the real world time to next treatment was defined as the time from index date until the start of next systemic therapy or death in the absence of next systemic therapy. And real world time to treatment discontinuation is the time from the index date until the earliest date and date of osimertinib associated with discontinuation on or prior to first line of therapy. Next slide.
Sir, sorry to interrupt. Kindly conclude your talk in 2 minutes,
That's
please.
few slides. So demographic characteristics was similar. Next slide. Characteristics were similar, whether the histology or the stage. Next slide. This is also same. The EGFR mutation was seen. All the EGFR mutation were taken into consideration, and 318 patients, that is 58%, remained on the first osimertinib therapy, and therapy around 18.8% received the second line treatment. Around 18% patient died while on the first line, and 4.7% discontinued. Next slide. The median follow-up was 9.6 months, and the time to next treatment was 17.9 months. Next slide. Similarly, in the multivariate analysis, following factors they favored significantly: stage at initial diagnosis, smoking history, the Charlson comorbidity index, EGFR mutation, and the number of metastatic sites to be equal to more than equal to 4. Next slide. Median time to treatment discontinuation 17.2 months. Next slide. And the foreign variables were significantly associated with the time to treatment discontinuation. As I told you, ECOG performance status, EGFR status, number of mets to be equal to more, and the evidence of liver mets. Next slide. So the take-home message: this study provides real-world insights into the use of osimertinib in the patient with this disease based on the first data cutoff and also the US population. In the interim, real-world time to next treatment and time to treatment discontinuation results support the effectiveness of osimertinib in the real-world population. And a longer-term follow-up is required for the substantiation. Next slide. So this will be all from my side. Thank you so much.
Thank you, Dr. Devinder, for such a lucid discussion. Now I would like to call for a panel discussion. I want that our speaker will also stay with us because they have deliberately given some evidence-based things, and I want that they should discuss in the case discussion. I would like for a expertise opinion by Dr. Priyanshu Chaudhary, Dr. Piyush Mehta, Dr. Rajiv Saini, Dr. Mukesh Bansal, and I prefer that our speaker should stay during the discussion time. Srishti? This is the basically early lung cancer patient. I want that expertise will give their opinion, the evidence-based, what they are doing in clinical practice. I want that they should openly discuss this case as a clinical case, which they are doing in their clinical practice. So 67-year-old gentleman, non-smoker, presented with mild cough. X-ray chest shows a small lesion in the left upper lobe, and the PET CT scan showed lesion in the left apical lobe, and this is the picture of PET CT. Anybody can take a comment whether they will go for a bronchoscopic biopsy, CT guided biopsy, why, and how they will approach in such lesion when there is no specific node except the peripheral lesion, which is approximately 3 centimeters. Dr. Mukesh Bansal.
Sir, I will like to go with an bronchoscopy guided biopsy, preferably IBUS guided biopsy. And
Okay.
depending on the results, depending on the size, sir, I think size of the
Approximately
lesion.
3 centimeters.
Okay, okay, sir. So I think, and I will like to go with biopsy only. I think MRI brain can be spared if there are no symptoms, and depending on the biopsy results, we can proceed.
Dr. Mehta. Dr. Mehta. Dr. Piyush Mehta.
Yes, sir. Yes, sir. Good
Dr.
evening.
Piyush Mehta. May just see this PET CT. There is a lesion, no nodes, peripheral lesion, maximum size, maximum, my word is 3 centimeters.
So if
CT
the
guided
lesion is,
biopsy, bronchoscopy.
sir, CT guided biopsy is if the lesion is peripheral and accessible, then definitely will prefer CT guided biopsy.
Not the bronchoscopic, as Dr. Mukesh Bansal mentioned.
If it is peripheral lesion, then I might choose biopsy, which is CT guided.
Okay. Okay. Dr. Saini? Dr. Saini, what you are doing at Jammu? Dr. Saini, Dr. Chaudhary.
So
Dr. Chaudhary,
preferably CT guided, sir.
CT guided.
Posteriorly,
What are the
yes, sir.
chances of pneumothorax in such cases?
Practically, sir, less than 5% I've faced pneumothorax.
Less than
And
5%.
yeah.
Less
So
than 5%. Dr.
it also
Devendra Paul. Dr. Devendra Paul. Dr. Sumit.
Good evening, sir. And this
Good.
patient?
Yes,
Yeah,
this
sir.
patient means my question is very clear. There is
Yes,
a small
what-
lesion, 3 centimeter. This is the PET
How
CT.
to do the
No
biopsy?
notes. CT guided biopsy or bronchoscopy?
Yes, sir. Yes, sir. So, it depends
So,
on
with
the
some technical
expertise.
glitch.
So,
Huh?
if the main issue is we want a good amount of tissue so that. Yes. Hello, sir. Hello. Am I
Yes.
audible, sir?
Yes, yes.
Hello,
Yes. Sumit, you are audible. Yes.
sir. Yes, sir. The idea is to get a good amount of tissue. So it depends
Yes.
upon the expertise and availability of the infrastructure. So in
Mhm.
our center, we are very comfortable if it is a peripheral lesion. I will prefer to go for CT guided biopsy because
Mhm.
that will give me a more amount of tissue.
Okay.
Yes, the risk of pneumothorax is there, but that can be looked
Okay.
at. Sir.
Okay. Dr. Devendra Paul, what you are doing at Ludhiana?
So we are also following the same principle. If the lesion is peripherally located, it is better to go for a CT guided biopsy. But if it's a central located along the bronchus, so we can go for bronchoscopy also.
Means I discuss with my chest physician. Sometimes they are saying they are going for a bronchoscopic radial directed biopsy they can do. As I mentioned clearly, we need a more tissue, and Dr. Sumit clearly mentioned about that. Basically, they need a more tissue, and the CT guided biopsy is giving more tissue for diagnosis and further biomarker workup, which we have already discussed. Now, just see, this is the PET report. PET is showing a well-defined lobulated soft tissue nodular lesion in apico-posterior segment of upper lobe, and adjacent pleura tag features primary neoplastic etiology and no FDG avid nodes basically, and no evidence of other side metabolic disease, and biopsy is suggestive of adenocarcinoma of lung. My question to all the panelists, anyone can take this question, what next? Dr. Mukesh, you mentioned about the MRI imaging test.
I think, sir, if the nodes are not there and lesion is small, so MRI is not needed. Biopsy we have
Yes.
already done. Lab test, the routine test, CBC-LFT, KFT, and depending on any other comorbidity, and then a tumor board discussion, preferably for a upfront surgery.
Okay. Dr. Chaudhary, Dr. Chaudhary.
Sir, a whole body FDG PET CT.
Yes, we have
And
finished FDG PET. We have done.
Yeah. So
Any other imaging before surgery decision?
a PFT.
Yes.
And
Yes.
lung reserve evaluation.
Yes.
And MRIs are less than 4 centimeter, usually not required. Stage 2
I
onward.
mentioned 3 centimeter tumor.
Yes. And I guess medicinal staging based on the PET CT reports.
Okay, Dr. Mehta.
Yes, sir. Agreed. PET CT, biopsy, and PFT for pulmonary reserve. That's it. And like tumor board discussion, and to take this case for a surgery upfront.
Okay, Dr. Sunil Saini. Is Dr. Sunil Saini available for discussion?
Sir,
Dr. Yes.
Network issue, sir.
Okay, Dr. Sumit. Dr. Sumit Goyal. Hello, Dr. Sumit Goyal. Anybody want to comment on this? Any other diagnostic test? PFT they mention about, cardiologic clearance they mention about, MRI is option. Anything?
So echocardiography, and if the patient has any CNS symptoms, then only MRI.
Okay. Just see, would you recommend brain MRI stage 1B is an optional thing for MRI when there is no node. My question is, any role of pathological oblique mediastinal staging in early lung cancer when PET is not showing any uptake? Before surgery, during surgery, after surgery? Mukesh, Dr. Mukesh Bansal.
Sir, if the lesion is small, less than 3 centimeter and peripheral, then there is no need of mediastinal staging. But if the lesion is central, however small it is, or if it is a more than 3 centimeter lesion, whether the PET is showing uptake or not showing uptake, we should go for a mediastinal staging. If the PET sheet is not showing uptake and we are going for primary surgical section, and then it can be done during the surgery. Otherwise, it should be done before surgery if it is a discrete N2 or N3 nodal involvement. And is getting tissue biopsy a challenge? Obviously, sir, tissue biopsy, getting a tissue is always a challenge in lung cancer.
Yes, yes. Dr. Mehta, any role of pathological mediastinal staging workup in early lung cancer before surgery, during surgery, or post surgery? Dr. Mehta, Dr. Chaudhary, anybody can comment.
So before surgery, definitely the surgeon would like to rule out any N2 disease basically. So
Yes.
And if so that because they don't want to open and close. And so if PET is negative, I think so peripheral lesion, depending upon the surgeon, they can go ahead and the rest they can do during surgery, at least in this case.
Okay. Dr. Mehta. Dr. Mehta.
Pathological, definitely. Before surgery, if we are planning for a surgery, then to rule out the N2 disease, definitely would like to do a mediastinal biopsy.
Okay. 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 Means this is the guidelines. I'm not going in detail. Stage 1B, the MRI is optional, and after that, stage 2 to stage 3A, MRI is indicated if patient is symptomatic. So this patient has a US, no enlarged mediastinal lymph node, medically fit, and underwent surgery after the tumor board discussion. And just see the picture. Now, this is very important. The tumor size is 2.9, as mentioned, less than 3 centimeter, 2.5 and 2 centimeter, single tumor only, invasive adenocarcinoma, acinar, predominantly micropapillary, 25 to 30%, histopathologically moderately differentiated, visceral pleural invasion present. I am saying visceral pleural invasion present, LVI negative, margins negative, and out of 3, 2 lymph node in bottle, 2 positive, and pathologically the stage is T2N1 clinically. So my question is, next step, biomarker testing. And we already discussed in the deliberation of Dr. Chitresh Agarwal that the biomarkers play important role. My question is, pre-surgery on a same tissue, would you like to go for a test, or you want a more tissue for specifically NGS or a biomarker? Dr. Mukesh Bansal.
Sir, I will like to go for EGFR testing in this case, preferably on the surgical specimen to decide for the adjuvant therapy. And in early lung cancer, usually we are doing only EGFR as of now.
Okay, okay. Dr. Mehta? Dr. Mehta?
Sir, EGFR testing.
EGFR testing only?
Yeah.
Okay. Dr. Chaudhary? Dr. Chaudhary?
Sir, EGFR, ALK, and PDL1 all, although there is
Three?
no targeted, yes, not targeted therapy for ALK, but if EGFR and ALK are negative, then we can go for a PDL1 or if it's more than 1% for different Atizo or Pembro, whatever we say.
Okay,
So just
not
for
NGS? Not NGS?
no, sir, I specifically test for all the three on the surgical specimen.
Dr. Mukesh, you want only the EGFR or you want an EGFR, ALK, and PDL1?
Sir, in my practice, I'm going for EGFR only because I am not aware if for adjuvant in this early tumor, if any immunotherapy is approved for the adjuvant setting, at least I am not following that.
Atizo and Pembro are approved.
Atezolizumab?
More than
In
1%.
Yes, more
in
than
in
1% CPS score. Yes.
in stage one, sir. Stage one.
No,
T1,
It's
T2
node
T2,
disease.
positive.
T2,
This is node
N1, node
positive.
positive, node positive,
Okay.
N1
Okay.
disease. N1
Okay.
disease
Okay. Okay, sir. Okay. Okay.
means even if tumor size is more than 4 centimeter and node positive disease, you can go for a neoadjuvant immunotherapy oblique chemotherapy as per the NCCN guidelines. So PDL1 is important in the sense if the tumor size is more than 4 centimeter or equal to that and node positive disease, you can go for nivolumab plus chemotherapy as an option or pembrolizumab plus chemotherapy as an option in neoadjuvant setting in lung cancer. So this is the, do all patients with early lung cancer stage 1 to 3 undergo surgery, and which patient you feel that is not fit for surgery? Dr. Mukesh.
Sir, no, not all patients undergo for surgery. Around half of the patients don't undergo for section. They are medically inoperable, comorbidities, patient
Yes.
refusal for the surgery, unavailability of expertise, whether VATS or a expert thoracic surgeon. So these
Yes.
are the reasons.
Dr. Mehta.
Yes, sir. Patient's performance status and the availability, the institutional expertise.
Yes.
Hmm.
Means what percentage of patient undergo surgery in clinical practice?
So in my
Stage 1 to
practice,
stage 3.
I haven't seen in the last 3 or 4 years a single patient going for upfront surgery.
Okay. Okay. Dr. Chaudhary.
So less than half of them, probably 40% would go for surgery. Rest would go for SBRT probably or other therapies.
Okay. Means if you see the data, they mention about roughly 20 to 21% patients underwent surgery from stage 1 to stage 3 as per the world data sees. But in India, most of the patients are having a locally advanced disease, stage 3B or stage 3A or stage 4. We have seen most of the patients are in stage 3B or stage 3A and stage 4. So I totally agree with you that 50% patient in Indian real world picture is not fit for surgery despite of a diagnosis. So what factor should be considered in determining resectability? Means as a medical oncologist, suppose you are investigating one patient, what are the criteria which show that this patient is resectable or this patient is fit for CTRT or this patient is fit for neoadjuvant? I clearly mentioned any tumor in the lung which is more than or equal to 4 centimeter or node positive disease should be subjected for neoadjuvant immunochemotherapy. If PDL1 is positive, nivolumab or pembrolizumab, this is the new concept, plus chemotherapy as per adenocarcinoma or squamous cell carcinoma. Dr. Piyush. Dr. Chaudhary.
So for
Performance.
determining resectability, you should first is the disease-related factors. It should not be
Yes.
an endo disease. Then the
Yes.
patient-related factors, definitely the performance status, the
Yes.
cardiopulmonary reserve, and whether the surgery is a lobectomy or a pneumonectomy. So that would be the criteria. What is whether there's underlying COPD, and so these are the mainly surgical factors which are patient-related. And then is the surgical experience, whether they would want for upfront surgery or not. So these are the factors in clinical practice.
Dr. Mukesh.
Yes, sir. I agree with what Dr. Priyanshu is saying. These are the factors.
So my next question is role of radiotherapy in early lung cancer, especially basically the adjuvant radiotherapy, whether it's SBRT, what are the results, whether this is detrimental, any advantage of radiotherapy in adjuvant setting. Dr. Mukesh.
Sir, if the patient is early stage medically inoperable, then obviously SBRT should be done. And role of which patient should obviously, sir, if the patient is not fit for surgery according to the performance status or refused for surgery, then he should be undergoing for radiation.
Okay. Dr. Mehta.
So that's the same, like if the patient is not willing or if the performance status is low, that if patient is not fit for surgery because of any underlying disease, then definitely in those cases only.
Okay.
Not, yeah, not for all cases in early
Dr.
stage.
Chaudhary. Dr. Chaudhary.
Similarly, sir, post-operative mainly in margin positive, I guess. Otherwise, not much of a benefit.
Okay. No adjuvant like a poorly differentiated carcinoma, veg resections, patient is having a neuroendocrine high-grade tumors, patient is having a high-grade malignancy.
Adjuvant
Suppose,
chemo maybe, sir.
yeah, adjuvant chemo. Yes, I totally agree with you. So this is the question which is now in 2023, and I personally feel that in 2024 we are more aggressive on this aspect, role of neoadjuvant therapy in lung cancer. And they mention about very clearly any tumor which is more than 4 centimeter or equal to that or node positive disease, and if the PDL1 is positive, CPS score is more than 1, subject to nivolumab or pembrolizumab plus chemotherapy as per histopathology, adeno versus squamous, paclitaxel, gemcite, pemetrexate, totally depend upon that. The 3 cycle of nivolumab and then clinical assessment. So post-surgery molecular panel, as Dr. Mukesh mentioned, he prefer a EGFR. Anybody post-surgery prefer a NGS? Post-surgery, do you feel that NGS is required for a rare one also? Because Chitresh discussed so many things. MAT, RAT, TROSI, so many PDL1, ALK.
So not yet approved in adjuvant, but we can do that just in the case because in future it might help if it progresses.
Yes.
Otherwise, not yet approved in adjuvant.
Yes. The future will definitely change once you have a rare mutation. Dr. Mukesh.
Yes, sir.
Role of adjuvant chemotherapy, role of ositinib as ADORA trial discussed by us.
Yes,
Which one
sir.
is your choice?
Definitely in this page.
Suppose EGFR mutation is positive.
Yes, sir.
Then what is your choice? Chemotherapy if poor risk or EGFR is mutation is positive?
Sir, first 4 to 6 cycles of adjuvant chemotherapy. In this patient, it may be pemetrexed cisplatin or vinorelbine cisplatin, and then followed by adjuvant osimertinib.
But patient has a surgery, need a adjuvant treatment. How many cycle would you like to give adjuvant?
Sir, around 4 cycles, sir.
4 cycle. Dr. Mehta?
Yes, sir. Like, so it's the same. In Hello.
Yes, I'm listening.
Yes, sir. So we'll give like osimertinib for to like in patients. Hello.
Yes.
Yes, sir. Sir, if EGFR mutation is positive, then I would like to give osimertinib. Yes.
Okay. Suppose EGFR is positive, PDL1 is positive. What is your choice?
So then EGFR targeting, yes, sir.
Not PDL1?
No, sir, not in this.
Why?
So if it's a driver mutation, then we'll target it first as compared to the.
Yes. The response is not much with the PDL1.
Yes, sir.
Means very clear. So role of adjuvant chemotherapy in patient, benefit of adjuvant chemotherapy. Dr. Mukesh, how much benefit you can give once you are going for adjuvant chemotherapy or even the osimertinib as a third line TKI? And which drug would you like to add as an adjuvant treatment? Dr. Mukesh? Dr. Mehta? Dr. Chaudhary? Anybody can take this question.
So platinum-based adjuvant chemotherapy, the LACE meta-analysis had around 5% benefit.
Yes,
and
5.4% benefit reported.
Yes, sir. And
Five-year
sir, in
survival.
yes, sir. In adeno, pemetrexate plus cisplatin
Yes.
is tolerated better compared to vinblastine plus cisplatin. There's data phase 3 trial, and so I think so. This is the drug of our choice. 4 cycles of pemetrexate and cisplatin in adeno. In squamous, either docetaxel or gemcis is my practice.
Okay. Any comment from anybody?
Yes, sir. I Agree with Dr. Priyanshu. Benefit of adjuvant chemotherapy is definitely there. Around 5 to 6% survival advantage we can add. And
Yes.
obviously, in adeno CA, it will be Pemetrexed plus cisplatin. It is the
Mhm.
better tolerated drug. Around 4 cycles should be given.
Okay, okay. So you can see that there is a 5.4% benefit seen with 5-year overall survival benefit. These are the 5 randomized trial done, and as per the stage, this is the advantage seen in adjuvant setting. And this is the, as per stage, this is the alive patient at 5 year. Stage 1 is 64%, stage 2 39%, and stage 3 26%. The role of adjuvant ositinib in the patient stage 2A, as per the Aurora trial, the important thing is that what your clinical practice, Dr. Mukesh? Disease-free
Uh,
survival or overall survival?
So I think both have a role. In my clinical practice, very minute number of patients undergo present with early stage lung cancer, and
Mm-hmm.
lesser number of patients undergo surgery. So adjuvant chemotherapy is a very rare thing as far as lung cancer is concerned.
Mm-hmm.
So I have not till used adjuvant osimertinib in my practice. Either the
Mm-hmm.
patient is not affording or surgery is not done. But otherwise, I think the data looks promising, and it is the future.
I'm totally so happy. I tell you, Dr. Mukesh, you tell us about the real world picture that the surgical patients are really very less in India. And most of the time, we are dealing with the stage 3B with concurrent CTRT or NACT, followed by CTRT, or the adjuvant, you can say it's post CTRT, dolazumab or other things as an adjuvant treatment, post CT rather than I'm talking about that for 1 year period. So, anybody is commenting on this Adara practice changing trial? Really, this is changing trial as a disease-free survival is better? Dr. Mehta, Dr. Chaudhary, anybody can take?
Sir, I mean, we are using TDM1 in and out just on the basis of DFS data. So
Yes,
why not osimertinib? I mean,
yes.
it takes time for the overall survival to mature with fewer events in the initial year probably. And
Mm-hmm.
so it is actually practice changing because in early stage, as you had shown in the previous slides, the
Yes,
5 year survival drastically reduces from stage 1 to stage 3.
yes,
So
yes,
if
yes.
affording, definitely we should use, and
Mm-hmm.
we have a targetable actionable mutation, so
Mm-hmm.
we should be using it if there's no contraindication.
Means I'm highlighting one important thing. Chemotherapy for high-risk patient and osimertinib also, as per the guidelines. Recent guidelines says, and everybody knows that high risk means patient is having a poorly differentiated carcinoma, grade 3, neuroendocrine high-grade tumor, wedge resection done, are the indication of adjuvant treatment for patients. Thank you very much. The expertise, those who are given a real world picture and clinical picture of their day-to-day life. I thanks all the expertise, speaker, panelists for this scientific update on lung cancer. And I hand over mic to the organizers for vote of thanks and good night to all of you.
Thank you, sir.
Thank
Thank you,
you, sir.
everyone.
Thank you, sir.
Thank you, everyone, for joining. And it is, I think, almost all the second last day of the year. And we wish you a very happy new year to everyone present here who has attended the meeting, and very good discussions and talks. So thank you, everyone, once again for joining, and good night, everyone. Thank you,
Good
sir.
night.
Good night.